Now we are being recorded. But today's topic on youth and substance use has again been really an important topic for United Way. It's been more than a few years. One of our community surveys had identified substance use disorders. Out of that community survey, a group was started some time ago called Our Futures that worked with our schools and our communities in addressing substance use disorders, particularly working with youth. A number of our funded partners throughout the years have worked really diligently in this area as well. And so we are really pleased that together, everybody working together, we've had some successes. And currently, as we go into some of the changes in this area, it's a call to action again for all of us to continue to work together in addressing what's new and around the corner. One of the things that you can be assured of is that the types of drugs, the types of use and abuse that we see changes from year to year, and there's always needed fresh approaches as we wrestle with these issues in our community. I want to say thanks again to all of you who support United Way. We've got a few wonderful upcoming topics that you'll see going into the new year. If you haven't seen what those are, please check with Corey over there at the desk and grab a brochure looking already at 2026 topics for next year. And of course, in February, we know that our not-for-profit expo is just around the corner. We will be starting to receive applications for that expo again, and we hope to have everybody participate this year and keep that momentum going. We are still in the thick of United Way campaign season, so as always, if you have not yet had an opportunity to make a contribution to United Way, please know that your dollars go right back to the community to help make a difference in a variety of different areas. And substance use disorder, working with our youth is one of those areas, as you'll hear from our speakers here today. So please make that donation today. You can give by check, you can give online through unitedwaylc.org. And then finally, one other announcement, we do invite you to come back and join us at the DoubleTree next Tuesday evening at 6 p.m. as we continue our community conversations on homelessness and housing, and as we take a deep dive into the financial stability of households here in Licking County, and a deeper dive in what the Alice demographic is wrestling with day-to-day, struggling just to make it each week. How do I juggle the expenses of healthcare and housing and transportation and food and all of those things in our community? So please join us next Tuesday at 6 o'clock at the DoubleTree. With that, I'm going to go ahead and turn it over to Corey Stutes, who will be introducing our panel and getting us right into our conversations. Just a reminder, if you have a question for today, go ahead and write that on the slip of paper on your table. We'll collect those questions at the end and then allow for some community participation. Thanks so much.
All right, thank you, Deb, and good morning, everybody. Thanks for coming out on this Wednesday morning. Thankfully, a little bit warmer than it has been the last couple of days, so not quite as bad to get out in. But we do appreciate seeing you. If you haven't already, go ahead and grab yourself a cup of coffee and get some food and settle in. Feel free to get up and get stuff as you need. As Deb said, I'm going to be moderating today's conversation. We are joined by a wonderful panel who all work within this topic from different perspectives. So we're going to have a really good, well-rounded conversation this morning. So joining us this morning, we have John Jordan. He is the Executive Director of LAPP, where he leads strategic operations to advance substance use education and barrier-free treatment across Licking County. We have Samantha Wilson. She has worked for over 34 years as a licensed social worker, 20 years with Licking County Children's Services, and for the last 14 years, She's worked at Licking County Juvenile Court. She's currently in the role of Senior Court Services Officer and Program Coordinator. Finally, we have Cheryl H. She has been with Pathways of Central Ohio since January of 2018 as the Director of Center for Prevention Services. Before that, she worked as an adult and adolescent chemical dependence counselor at LAPP. She's also a board member on the Ohio Chemical Dependency Professionals Board with an LCD C3. So let's give our panel a big round of applause. Welcome. Really go, Shelley. Now, our panelists have been provided some questions in advance to guide our conversation, but as Deb said, if you have questions throughout the discussions this morning, please feel free to write those on the slips of paper. Towards the end of the conversation, we will gather those so that your questions can be asked to the panel. And with that, we're going to dive right in. So panelists, each of you, as we've learned, work with youth in a different capacity. If you could, please share a bit about your organization and the work that you do to serve youth, especially in relations to substance use. Might have to click that. You just push that button.
Hello?
Yeah.
Obviously, I've never used one of these before.
It's not doing anything.
Oh.
There we go.
Okay. I'm Cheryl again. I work at Pathways of Central Ohio. Our agency does a multitude of things, but our department, which is the Center for Prevention Services, we go into school districts and work with, obviously offer prevention. We can do kindergarten all the way through high school. We have different curriculums that we use, and that's changed over time depending on what the needs of the students are. Obviously, we started many years ago with Bottom Life Skills and Project Alert. Bottom Life Skills was our social emotional learning curriculum. Project Alert was our drug prevention, but over the years, we've moved most of our programming to the Mendez Foundation. Too Good for Drugs, Too Good for Violence, social perspectives. A lot of the same topics are covered, just they do it with more activities, which gets the kids more engaged, because if anybody knows, school is not like it was when we were there. It's not just lecture based anymore. So it has a lot of board games and role plays and things like that that reinforce the information that we go over when we're in the classroom. We also, in the last 5 or 6 years, have added a lot of vaping curriculums. It's a huge issue, epidemic. So we have Stanford Medical Vaping Toolkit that we use and Catch My Breath. And then we have bullying prevention curriculum as well. Other 8 departments, we obviously Pathways runs 211 and 988. And then we have another department, parenting center, who goes in and works with New York City kindergartners and does parenting classes.
Ladies first.
Hi, I'm Samantha Wilson. I'm with Licking County Juvenile Court. Currently, I work as a senior probation officer, which means I assist in the supervision of the other probation officers. Our department's made up of probation officers, diversion officers. We also have an assessment center that was recently developed. That role has changed a little bit, so it's continuing to develop and grow. But part of the responsibility of the assessment center is to assess families in crisis and link them and refer them to services so that they can make those connections. And most of our involvement with youth as far as substance use is in regards to supervising our caseloads of children who have criminal charges for one reason or another, or even unruly charges.
I'm John Jordan, Executive Director at LAPP. Formerly known as Licking County Alcoholism Prevention Program. Prevention's in the name, however, that's not what we do. We've evolved over a number of years, close to 60 years. Started by United Way in 1968. We evolved into a dual diagnosis treatment facility, providing services for mental health and substance use. Substance use is our primary focus on treating folks, but we do have licensed clinicians to address mental health issues as well. We know that they work hand in hand. You have depression, anxiety. Sometimes that fuels the substance use. Sometimes substance use creates those, right? So we have to treat the person holistic So we've molded into that model over the years. We primarily right now, because of numbers, and hopefully that changes after today, we serve adults, justice involved folks. That's majority of our folks that we engage with. Anybody with substance use disorder doesn't believe they have a substance use disorder till it's too late. And then it's because a family member made them come or the courts made them come, right? So we have a negative image of a consequence, but we are far from. We're a treatment provider like any other provider in the community. We just work with unique population that unfortunately, sometimes we're their only lifeline to their own freedom or choices in their life. As far as adolescents, when Cheryl was there, we had a strong adolescent program. The community understood that kids needed more help. Cheryl was serving on committees. I was an intern at the time, and Cheryl was going to committees and school meetings and a lot of things and really building up that support so they understood what LAPP actually did. COVID happened. Cheryl left. A lot of things happen. We do have providers that can serve adolescents. The bad thing is when we get contacted by the public, hey, these kids are using drugs, what do? We say, well, we put them in treatment. We're like, I don't know if it's there yet. And that's a barrier to their services to get them better. So hopefully after today, you'll get a little bit more information to be able to find out what services are available and how we can get there together.
All right, thank you, panelists. So when we talk about youth substance use, what exactly are we talking about specifically? Are there certain substances that you see most often? And what ages do you see most often in your work? And that might vary depending on who's answering, but in general.
As a treatment provider, a substance is a substance, doesn't matter what it is. That's why they've changed it to substance use disorder. If you're addicted or dependent on a substance, that's what it is. Because it can be interchangeable. It could be marijuana one day, it could be methamphetamine, it could be opiates. You just treat each one differently because you have different side effects and withdrawal symptoms and how you manage those. Essentially, a substance and addiction is an addiction. So that's irrelevant. What we do see a growing need of vapes, right? Vapes a huge one for kids. We don't know what's in the vapes. We don't know if it's nicotine. We don't know if it's THC. We don't know if it's methamphetamine. We've had adults that are testing positive for methamphetamine using vapes that they didn't even realize was in it. To others, that might sound, well, how do you not know? But it's true. We had a kid in a local high school overdose on a vape that he's never vaped before. First time use, it had opiates and went down. Went to the hospital. Luckily, he survived. But those are the risks that kids have because kids are going to try things. And statistics, 1 out of 7 tried an illicit drug before the age of 12. 1 out of 7. Times have changed. It's more readily available. Before it was sneak a sip of beer, but now it's take an extra pain pill or taking grandma's pill. Marijuana that's older sibling or older friends have. So things have changed significantly. For now, so that's from a treatment aspect. They're all the same. You just have to address the symptoms a little differently.
From a court aspect, we're working primarily with youth around age 12 and up. We are getting some as young as 9. They're starting to get some involvement with the court. Usually that's kind of the front door in, but it goes from there. Primary drug that we see would be THC. We do have some youth that are using meth, and then we get an occasional heroin or fentanyl, which is really scary. And like you said, the kids aren't really thinking about what they're doing. They'll grab a vape off of someone else and just hit it. They don't know what's in the vape, but they're just doing it. It's big around schools. They pass them around. They get them for each other. They just are very willing to share those. Kids are even getting them from their parents. We've had some issues where parents are calling saying, hey, they stole my vape. well, it's like, maybe you're gonna have to work on securing it a little bit better, but, you know, so that's been an issue as well. So I think those are the primary that we're seeing right now. Our THC is definitely the biggest, but we, like I said, the meth, we do have some kids that are pretty regular users for that.
The top three for adolescents for a long time have been alcohol, cannabis, and nicotine. Those have changed over time. Alcohol used to be the number one, and then it was marijuana and nicotine. Those changed drastically. Right now, I think it would be marijuana, nicotine, and alcohol as far as the most abused ones. In the school districts, we are seeing students use other substances, but it's far and few between. And for us, for prevention, the youngest age of initiation remains the biggest risk factor for use and addiction issues. So we, a program last year, an early initiative with a school district, that we would see any students that was their first time getting caught using a substance. It was for middle school and high school. And I had made them, because of my treatment background, very clear, more than likely any high schoolers we're gonna be seeing are gonna be in at least moderate, if not severe, and have dependence issues. We very quickly, I started doing surveys from treatment to give data back to the school about how that was occurring. I mean, we were seeing kids in middle school that were dependent already. So then we worked with the school district to work more with LAPP, and we even had the counselors trained to do screenings, so that if the kids were in mild level, they would see us for prevention, and if they were moderate to severe, they would be referred for assessment and treatment. That was a whole year of us working very diligently to train the school to understand prevention doesn't work with dependent students. So.
All right, thank you. Well, speaking of prevention, one of the phrases that we hear a lot is the best treatment is prevention. So with all of that in mind, when should conversations about substance use disorder start? And is there any age that's too early or too late?
Oh, boy.
Loaded question. I know.
Prevention is not treatment, so I want to be really clear about that. But prevention can start as early as kindergarten. You know, 20 years ago, if you asked a student in a classroom, is someone in your family dealing with a dependence issue or substance use disorder, which was called something different, you know, you might have one kid raise their hand. We ask the students now, and the majority of all the students raise their hand. And it doesn't matter what age population. So students are more aware, they're more educated, they're seeing it on social media, it's in their families. People act like kids don't see, and they absolutely see and understand. And that can lead to earlier use, it can lead to lack of understanding. We had one student tell us that he let his 4-year-old sibling vape. So obviously, the younger someone starts using, the more addictive they could become, the more impact it can have on a developing brain. So with prevention, we focus a lot on risk factors and protective factors. Give students the education, and we tell them all the time, we're not here to make decisions for you, that's not our job. It's to educate you, so when you're more educated when you make decisions you make it on a daily basis. We focus a lot on educating the students to what risk factors put them at a higher rate. And we also work on what can be protective factors to keep you from having to experience that. Hopefully I answered all that.
Let me just pass this on to you.
Sure. Cheryl and I work a lot in the community to, communicate and educate the public about what differences prevention and treatment. A lot of times schools will call and they want a blanket. They're running in crisis. There's a lot of kids vaping. There's a lot of kids using substances. A lot of kids getting suspended from school based off the rules and policies that they have in place. I try to help the schools understand treatment. It's not a one-time fix. Go to lab, do it, you're done, you can come back to school. Let's keep them engaged in social activities like being in school while they're getting treatment, because they need to be in that environment to learn how to navigate it with that disorder that they have. So that's one, I try to communicate. Two, that once they start using, it's not prevention. Schools will come up to me and say, hey, there are a lot of people using, I need you to come talk to a classroom. I can't do that. That's prevention. That's generalizing the whole classroom that somebody's got an issue and I'm gonna speak way above their head because I'm trying to address the one or two in that room, right? Cheryl can come in there and give that general education and tools and interventions to help prevent use or going past that one time just experiment. So that's one thing. And that's huge because we have several school districts and they all operate differently. I have one school that says, an assessment's an intervention, they can come back to school, they're good. Or they're a great athlete, they can't have a problem, they can come see you, let's get them back on the field. Well, they can still be on the field and come to treatment, it's okay. The support from the schools, to help that student understand that they do have a disorder. Not treat them differently, but understand that they have a disorder is huge. And that goes to parents, family, everybody. They have to understand that the disorder is real. It's accepted, just don't treat them differently. Like treating them differently is like, you can't come to school or play football because you have this disorder. Will we do that with somebody who has anxiety? No, we'd encourage it because hopefully you can work it out, But that's a misconception between treatment. Like once it gets to treatment, it's really bad. So, we're taking them out of all these things, but prevention is more acceptable. And I think that's the biggest misconception because we go hand in hand. Even though we don't do each other's work, they do go hand in hand and they should be valued and viewed as the same.
All right, thank you. Really insightful so far, so I appreciate all of your answers and obviously you're drawing from so much experience. So thanks so much for that. For those in the room who might not know, what current strategies are being used in Licking County to address prevention, intervention, and treatment for youth using substances? You touched on this somewhat, but in terms of what are you actively doing in your roles or that that others might be doing in order to address this? And how are the youth responding to these efforts?
So I will say that being a treatment facility, we use evidence-based practice only. We use a lot of stuff from SAMHSA. They have great guidance on mental health and substance use. We use a matrix for adolescents. There's a early intervene, teen intervene program that we use for a very mild early intervention treatment. It's still treatment, but it's a mild diagnosis. We're still trying to target severe to moderate diagnosis substance use disorders to really get deep down in there. But the first step is getting an assessment. A lot of referrals say, hey, they just need to come take a class. I'm like, well, I'm glad you diagnosed them and found out exactly what they need. But it all starts with assessment. We can do a full diagnostic assessment, find out truly what they need, where they meet the criteria for diagnosis, and what treatment options there are. That's step one. There's a lot of referral sources want to dictate treatment, but it's not true. You don't refer somebody to a surgeon and say, hey, I want you to cut here and here. What's the point in having a surgeon? You could just try to wing it in the back door. But we provide the assessments, we come up with a treatment plan that is trauma informed and person centered. If the kid's not willing to do it, we're not going to create a plan that they're not willing to do. It's getting the buy-in. So we employ motivational interviewing, cognitive behavioral therapy, MI, a lot of things, CBT, DBT. We have a lot of providers now that are performing a lot of different therapies to try to get you to that stage where you can understand it and learn from it. We also provide group and individual sessions, which is unique because when you put them in a group setting, they learn from each other. It's easier to point out a flaw in somebody across from you that you don't see in yourself. And they'll do the same. Then you realize that you have something in common. You build that bond that you're in it together and that this is real and you're not the only one walking through the recovery journey. So that's how we do it. And then we communicate with the parents. We try to get families involved. Unfortunately, a lot of our kids that reach treatment at our facility current times is court ordered through either juvenile court or children's services. And the parents aren't too involved at that time. At our stage, we try to get them better to, get back with their family as much as we can. We don't really see all the positive outcomes, so I couldn't tell you that side of it, but we do have about an 85% success rate with adolescents right now, which is huge. Again, a lot of it's mandatory to be there, but we do see personal growth when they're there and they're making progress.
I think it's hard, we don't have a lot of options for the youth that we're working with. And getting them to buy into it and see the need for it is important, but also getting the families to buy in and understand the importance. And sometimes it's their own substance use issues that are interfering with that, their buy-in into that. We do court order participation in treatment. But if they're not willing, then they're not gonna get a whole lot out of it if they're not actively participating and wanting to make some changes. Our job is really not in the prevention, but more in the education piece. Once we've identified that there are issues, we have an assessment tool that we use that determines the youth's likelihood for reoffending. It's an OES assessment tool, but one of the questions is about substance use. And I found, like, in recent years, the alcohol has decreased. You know, I remember when I worked at Children's Services, I worked with a lot of parents that had alcohol issues, which affect their parenting. And now I'm seeing that that's not such a big deal among the teens that I'm working with. Most of them will tell me they don't like it, they're not interested in it, don't like the way it tastes. It also seems to be easier for them to get the marijuana and the vapes anymore, so that's kind of where they aim for. But as far as like really pushing into services, I think that's definitely something we can continue to grow on in our community, and wrap around these kids a little better and help them be successful.
As far as strategies that prevention uses, all of our curriculums are evidence-based curriculums. Our funders require evidence-based, and obviously it's been proven to show it's effective, so it's important to use that. We unfortunately, like when we go in and see the students, we educate the, administrators, we educate the teachers. We don't have much contact with parents at all. So that's why we're in the community all the time. Pretty much if there's a community event going on, Pathways, our department is there. And that includes open houses at the school districts. That includes when Newark does, I'm trying to think of the event, Rally in the Alley, we're there. And so we are making sure we're out in the community to get to know the parents. And then of course, it's always better when you know the families, and you can be interactive with them, but that unfortunately, we don't have a lot. We do prevention, obviously, but we also do early intervention. Again, like I said, that contract with the school. How are the youth responding? The bigger issue we have is high schools will let us come in and do prevention. Historically, Pathways has been around for 55 years. I think we're on our 56th, actually. High schools and middle schoolers, we have relationships with that go back 15 years, and they're like, come in and talk to our students. Again, we want to do that, but since I became the director, we kind of moved away from the high schools. Initially, we were going into more middle schools, but right now my focus the last couple of years and needs to be is elementaries. Prevention works best before the kids are using, period. We have a lot of difficulties getting in elementaries. I brought some stats. Right now, we're scheduling 3 elementaries, and second semester, we're scheduling 3 more, which is great. That's 6 elementaries. But we need elementaries. And when we talk to administrators a lot, they'll say like, but we don't have a problem in our school. Right. And I'm like, yeah, that's why we need to be there before they're experimenting, before they're trying it, it's been really difficult to get in elementaries. So far this fiscal year, like I said, we're in 3 elementaries, 1 intermediate, 5 middle schools, and 1 middle school, and oh my gosh, I'm so sorry. 5 middle schools and 1 high school. To date, we have seen 7,126 students. And the majority of that is drug prevention, social emotional learning, and vaping. So.
All right, thank you. It's so good to hear, obviously there's work to be done in getting in those elementary schools, but just that number of the students that you have had contact with is, really encouraging to know that many kids are being engaged with, and, that's a lot of hard work. So those of you most of you probably know, and John mentioned, both LAPP and Pathways have been funded partners of United Way Licking County for a really, really long time. John, I think since the beginning.
Yeah, I mean, we were a program of the United Way.
Yeah, so, I've just continued to get to learn about the programming that they do. And every time I meet with them, I learn something else, and it really is just, it's so easy to focus on what work there is to do without recognizing the vast amount of work that has been done. So, that's not to say that there isn't more to do, but it's easy to get caught up in, kind of a dire situation without taking a look at, oh, wow, there are a lot of successes that have taken place. So big pat on the back for everyone here on the panel, just for the work that has been done and that they continue to do, in that vein. So we've talked a lot about vaping already, and I think everyone's kind of aware that that's been a growing trend, in the last few years. So we know that that is a primary concern, still for youth, whether it's nicotine or THC or something else. What are the consequences, for children or teens who vape, and what kind of treatments are there for vaping?
I'm gonna let John answer most of that, but I'm gonna start with, we're seeing younger and younger students vaping. The youngest that has been reported as a second grade. They're babies. Second graders shouldn't have access to vaping devices. But what we see in the school districts is schools with drawers and drawers full of vape devices that they've confiscated. Hundreds of vape devices they've confiscated. The problem is so large. I'll use an example of one district. There was a fifth grader that got in trouble a few times, suspended. He was up for expulsion hearing because he was taking disposable, used vaping devices and taking them home and rewiring them to work again and bring them to school and sell them to other fifth grade students. So, vaping is a huge issue. But it's not just, like we said, marijuana. And unfortunately, kids are seeing alcohol as a problem. They've learned. They're like, what's bad for you? But if you ask about marijuana or nicotine, that's not a problem. And with legalization, that's increased.
Mhm.
Then we're able to get a hold of it and things like that. So that's all played a part of it.
Yeah, I would agree with everything she said. A lot of the kids that are on probation are vaping, they're bringing them back to schools, they're doing that thing. They're getting suspended, expulsions, which is what some of them want, is not to be in school, so that works well.
Using.
Yeah, so they can accomplish that goal. But as far as like criminal charges or anything, there's nothing like that that's happening as a result of the vaping at this point, so I think that's John's turn.
Vaping. We don't get enough referrals for vaping. They usually throw them into drawers, hundreds into drawers. We don't get hundreds of youth in our building. 9 times out of 10, it's probably more than vaping. I can put my finger on it that they're using something else other than vaping. They're doing vaping, but they can't get away with something else. Adults did the same thing. They wanted to get away from smelling like smoke and being able to smoke in the workplace. They vaped. Kids learn that. Kids want to do that too. Unfortunately, when your brain's not in control and drugs have taken over, that's what naturally comes. It's not manipulation that they're trying to get one over on somebody. It's what that drug has done to that individual to survive to make sure they keep on having it, right? So schools try to combat that. Let's put the sensors up. Let's not get them a treatment. Let's put sensors up. Spend thousands of dollars on sensors where we can invest thousands of dollars in that kid's treatment to get them better so they don't have to put sensors up. Because guarantee the problem is bigger than just that vape and that sensor in school. There's a whole family dynamic that needs to get addressed. Is it normalized in that family dynamic where you have to treat the family? Or is there a mental health issue that this kid's struggling with and he's coping with it? Let's get down to the deep root. So it goes back to assessment. From a treatment aspect, assessment rules everything. You can't do anything without a clear-cut, informed decision on what's really going on, the big picture. In adolescent assessment, we talk to the kid, we talk to any collateral information we can get. A lot of schools, juvenile court, we'll try to pull up as much information as we can to make an informed decision of what's really going on with the big picture. If they have a family doctor, talk to a family doctor, because sometimes they're clueless when it comes to that, because they have a discipline that they're focused on. You know, if I have a broken arm, I want to go to a doctor. I'm not going to come see me, but if I have something substance use, I want to come to somebody that works for me, not me, but somebody that works for me. And that's just what it is. So treatment for vaping is very minimal, honestly. There's really not anything that's evidence-based out there other than trying to divert from nicotine and the prevention of using it all. And once they vape, you really don't know what substance you're treating itself. So it's more of a behavior modification if it's treatment at all with vapes specifically. But if it's the drug itself, we gotta figure out why you're using the drug and what drug it is that you're using, that you're dependent on. We don't have a nicotine specific treatment program. Look at Memorial has one. We referred there, we referred to the health department for other resources. We don't treat nicotine. We can give you resources, we can work on some behaviors with it, but nicotine like replacement, things like that, we don't have it. But that's, again, I think it's the approach we take about vaping is what the treatment needs to be. It's give them that assessment, see what's really going on. And I guarantee those numbers of vaping will go down because we're gonna address the root issue.
I want to add something to that real quick. I do want to add, Licking County Hospital doesn't do services with youth for vaping. It's 18 and above. I thought they did with youth at one time. I think they
Yeah,
did,
they
but
did.
they do not anymore. I just found that out not too long ago. And one thing I want to say too, it's really, really important is that parents and the community be educated. Because with any substance, the names change. Like right now with youth, Zens are a huge problem. Does anybody know what Zens are? It's
Yes.
dip. It's the dip packets. But it's Zens. So when they talk about it, people are like, well, I don't even know what that is. Well, it's the same thing that was a problem always years ago that when the kids were dipping. What? Copenhagen and the little pouches and stuff. So they taint, you know, obviously they don't want people to know what they're doing, so they change the terminology. And that's a huge thing. And parents don't know that or don't understand that. You know, kids are, if there's a will, there's a way, you know, you know that. So parents need to be aware to stay educated too.
Do you think, this is a little bit off script, but in certain areas, like I think Columbus, for example, they made flavored vapes illegal, the sale of them illegal. Now, certainly we know a lot of vapes on the market are illegal to begin with, but do you think that there are things from that perspective that can help?
Absolutely, and I know in 2018, you know, a huge thing was the Juuls for kids. It was really interesting to me, because I was doing treatment then, that the focus was only on Juuls. But there's hundreds and hundreds of other companies that are selling the exact same products. So Juuls was required to take the flavors out and things like that. But again, if you've been to a vape shop, there's still hundreds and hundreds of other companies that have different devices that are still allowed to do flavored. Flavored is a huge issue. Kids are gonna use something that's not, or tastes like whipped cream or butterscotch or whatever. They're definitely gonna be more enticed to use something with a flavor like that. It's a huge they need to really get rid of just flavored, period, to be honest, especially from a youth perspective.
I think from a marketing standpoint, yes, flavor would be great to go away, but if you're hooked, sometimes you don't know when you're gonna get hooked. It could be that kid's first time and they're hooked on a vape. And again, vapes aren't just nicotine either. You know, you don't hear strawberry flavored methamphetamine, but people are using meth, right? So let's throw that in perspective of a kid's developing brain who can't even rationalize that. He just knows that they feel better when they use the vape flavored or not. So I think from a marketing standpoint, it could lower some of the first time use, but I think if there's a will or a way, they'll push through it. Who, you can be open and honest in here, closed door, don't take it out, I don't care, I'm not judging. Who drank alcohol for the first time and loved it? Who hated it? Who drank again after that? Again, back to that same philosophy, you'll push through it, right? Cause I'll use my example growing up. I had a father who suffered from alcoholism. And when I was a kid, I was like, I'm gonna see what this is all about. And I hated it. When I got to high school, I didn't care what it tasted like. I wanted to fit in. Those are what normal teenage behaviors that most of us experience. Right? So if everything's normal to the extreme, that's the new norm. But I guarantee if I got caught, that either one be a consequence for stealing his beer, but you know, or I'd get in trouble at school and kicked out. There was no treatment back then. They put so much time and research in treatment. Now it's available now. We can use it and take advantage of it. That's the biggest difference. And I think that's across the panel, like the earlier the better to identify the true issue. So,
All right, thank you. You know, we could continue to dig into that topic. I'm sure we could do an entire panel just on vaping and, you know, from a countywide perspective too, that's been a big focus in the, community health improvement plan as well as focusing on that. So certainly, a lot of work that can be done, but thanks for the insights on, some of the ways that it could potentially be impacted. So one of the things, you know, we all talk about stigma all the time. Anybody who's touching anything to have to do with any kind of treatment, behavioral health. And we know it's a huge issue. So how does stigma and different kind of labels impact youth who might be trying to seek help? What shifts in how we talk about substance use could help reduce that stigma that could get more kids into treatment? And there's not a magic answer right now.
I think we discussed a lot of it already. Instead of viewing treatment as a consequence, because I hear a lot of times if they get caught again, I'm gonna send you to treatment. That turns it into a consequence. Say, if you can't do it, you know, by yourself or with our help, we're gonna have to reach out and I'm gonna add additional support. That's one way to reduce that stigma, especially in an educational setting, an athletic setting. Just say it's an extra support. Yeah, if you wanna do it your way, that's fine. Let's just keep track of it, because if not, I'm gonna have to, you know, ask for you to look out for some, or get some additional support from a professional who can help you. Who you can talk about anything and can't share anything with us at all. I think that's huge, because when referral sources send clients, sometimes they wanna know everything that's going on in that individual's life, and that's not the case. That's their business. You're there to educate and to ensure that they are healthy enough to reach their full potential in school, right? They don't need to know everything, maybe recommendations, maybe some accommodations if they need some. But everything else about their personal life, they can talk freely and not be worried about that. I think that's huge, in communicating it on the other side. We as professionals and licensed athletes and HIPAA, all that stuff, we can educate them. But if they don't feel that trust on the other end, I think that's a big barrier too as well, and that takes a lot of stigma. If it's a star football player, you know, have them swallow pride and walk into a counseling session and open all the way up. It's hard. It's hard because they're worried that it's going to get back to somebody else. Or, you know, coach is saying, I need to know everything that's going on for you to make sure you can play. That's not the way to approach things. It's, hey, we know you're struggling, go get help. You know, your performance will probably get better. I mean, that's how we do it.
I was gonna say too, adolescents are a little bit different than adults. When I worked treatment, you know, if someone had alcohol use disorder, they just drank. Or if they smoked marijuana, they just smoked marijuana. Youth are different. Youth, it's whatever's available. They may have a preference to a substance that but they're open to pretty much anything else if it's gonna give them the feeling or the high that they want. So that's one big issue with youth. But also stigma is different to youth. When we were doing those intervention groups, they had no problem at all telling us all the other, like, I got in trouble for this substance, but I use all these too. And like, this kid, and this kid should be in this group too. And, you know, it was bragging, like,
Yeah,
It's a huge.
that's what I was gonna say. A lot of the kids, it's like, street cred.
Mhm.
So, they brag about it because it makes them look cool in front of their friends. Or we have the other type that are like, okay, I'm failing my drug screens, but I can do it on my own. I don't need any intervention, any services or anything like that. And they'll give you a time frame, I can get clean in this length of time. So we have it either way. It's either kids that wanna try to do it on their own and kind of slide through, or the ones that think, hey, all my friends are doing it, their peer groups are doing it, and it's cool and it's natural because it's THC and, it's all good. So, and they feel like it just gives them more street cred. So I agree with Cheryl on that.
Mhm. No, I agree.
All right, thank you. So, within this conversation about youth and substance use, it's really easy to think only about, younger populations who are using substances. But we know that youth are impacted in many other ways by substance use. How might an adult's substance use, whether that's a parent, family member, or other adult in a child's life, how could that impact that child's mental and physical well-being and their likelihood of using substances in the future?
I think we all could jump on that one,
Yeah.
right? Yeah.
Obviously, if it's readily available in the home, the chances are much higher. The peer groups that they're using is much higher. How the family thinks about it, oh, it's just nicotine, it's no big deal, the chances are much, much higher. The family has a huge impact on access, opinions, education that they receive. Their peer groups, we have students all the time that, Cheryl, everyone is doing it. And I'm like, everyone in this classroom? And they're like, yeah. I'm like, they do 24 hours a day? No. I'm like, the reason you think everyone's doing it is because your peer group is all using. But you don't know that everybody in this building is using the substance. So again, it's their small world, what they're equating it to.
Yeah, many of the young people that the court gets involved with have parents that have substance use issues. So it's not uncommon. It's something that's been normalized maybe in their family. It also is readily available, like Cheryl said. And then the parents might also not feel it's a big issue because they have struggled with it themselves. So it's definitely impacting the youth.
Mhm. Um, yeah, access genetics. Genetics is a huge one. You don't have to answer, but just keep silent if you want. There's people out there who can drink and get a hangover, right? Somebody's probably experienced a hangover before. And there's some people who actually don't get hangovers, genetically do not get hangovers. That's going to give them more of a non-consequence to their excessive drinking, right? It is your body's saying, hey, I shouldn't drink because I got a hangover, I don't feel good. You don't pay attention, you keep going. And then somebody who doesn't get that, they're more susceptible. So genetics plays a huge part in addiction. Nature versus nurture, right? It's how you're brought up. If it's normalized, it's okay. Some families, they allow kids to drink alcohol at dinners, the holidays, things like that. If they can do it at home on holidays, they should be able to do it as an adult for sure. So it's discriminant culture, and it's not wrong or right. Nobody's here to judge anybody. It's just risk factors that you're adding on. Is the more risk factors that you have, the more risk of developing a dependency issue with the substance, regardless what the substance is. Yeah.
I just wanted to add, I think also the substance use disorders in the adults can cause chaotic home environments. They're not consistent with the discipline and the parenting, or even just showing up for their kids. So then I think that's why we see a lot of them on the court front, is because they've had that inconsistency and lack of structure.
I could talk about this one all day. As far as, when they've got parents that are in jail, obviously that's gonna have an impact on the family. So it's not just substance use itself, them using, but it can affect the finances in the family. It can affect food because drug use is being, money's being used for drugs. Parents in prison, if their students using, they're not necessarily worried about their physical well-being. So obviously we know that addiction is going to impact every person in the family, not just the family, but the community. But, that's a huge issue. We also have with youth, they don't like being told what to do, especially by people that are using a substance. I had a client one time tell me like, well, you know, my uncle's telling me how bad this drug is that I was using, but he's lighting up meth, standing right next to me on the porch as he's telling me how bad this drug is. And I'm like, well, how does that make you feel? Well, he's a hypocrite. So youth will use that at any opportunity they can get, you know, so family use has a huge impact on youth.
So you've demonstrated, there is already a lot of collaboration happening between prevention programs and schools and referrals to treatment and kind of that cross, collaboration. But how can we, as a community, as school systems, healthcare providers, collaborate more effectively? Are there things that we can do, to better support our community's youth?
Yes. A huge issue is a lot of people don't understand prevention. You know, we have that not only in school districts, we have that in agencies that, you know, obviously John and I have known each other for a very, very, very long time. So I think there's more collaboration probably now than ever with a treatment agency and a prevention agency. But that needs to happen. One district at the forefront, to be completely honest, they knew that there was problems in their school, so they reached out to prevention first, because we had a relationship with them. And then they also had treatment at the table. So when we started meeting with administrators and guidance counselors and behavioralists for the school and things like that, we were all at the table together to say, okay, this is what we can do as prevention. This is what you need to do for treatment. That needs to be happening more. Prevention is much cheaper than treatment. I will say that hands down, especially for us because we're free. So, there just needs to be more understanding what prevention is. There needs to be more administrators in school districts seeing the importance of prevention, and that we need to start at much younger grades if we're going to actually ever combat the problem that we're dealing with. Vaping is an epidemic. It's not just a problem, it's an epidemic. So.
And I think just to piggyback on that, like communication, the agencies need to communicate well with one another and keep those lines of communication open throughout the involvement with the individual.
I agree with Cheryl. I've been there through some hard and easy times, but I think every school, you know, every school has reached out and saying they have problems at the school with the substances. But they're always voicing, we want you to do this, which is prevention. I'm educating them with that. And then Cheryl will say the same thing. I don't do that. That's treatment. We try to formulate a process that they can understand and work in to make it easier to get them into treatment. But on the other side of it, treatment does cost. And treatment also is more invasive, so it takes parent buy-in too. I think bringing this to the table when they have those discussions in the beginning with their parents would be beneficial. I just don't have enough of staff to sprinkle everywhere because we operate off a fee for service. We don't do a service, we don't get paid. We never know what that looks like. Obviously, funding is huge. We don't have the numbers of youth coming in our doors to even a grant to even bat an eye at us. But most of the kids that's linked in with the system, a lot of times are on Medicaid through the courts or children's services. That covers costs. We do a sliding fee scale, and we do have some board funding. As long as the service is not done in the school, we have board funding that can compensate treatment. So far, we're pretty solid till the rest of the fiscal year. We don't know what next fiscal year looks like, but the levy passed. That's a plus. So that's good. We never come close to using much of our adolescent budget anyway. I usually have to reallocate it to other programs by the fourth quarter. So the money's there. So don't ever let finances be a barrier. Yes, it's not free, but it can be covered, and we find ways to cover it. And if it's enough adolescents coming in the door, there's ways to get funds. A lot of times schools ask for educational pieces and all this consultation. Well, that costs, you know, counselor's time. You know, every hour is accounted for a counselor. If you're pulling a counselor 3 hours to sit in the school to do one assessment, I'm paying somebody 3 hours and only can afford one, if that makes any sense. So it's a lot of what they want to tailor and cater, but if all the schools worked together and came up with a good schedule, maybe we could spin it off and make it work. If it was all uniform across all the school districts, so I think it's crazy to have so many in the first place, but, you know, have the same process down, like one school district gets a counselor this day. And this way we can build up a caseload at the schools and justify that cost of the individual. There's state funds that funnel through education and behavioral health. Let's try to, share resources to get the coverage that your schools need, the community wants, and hopefully we can get better results. We can't even get the data because nothing like that's in place. Once we get something in place, we can get the data to justify funding and outcomes, because that's what people really want to know. Do we do work, or what we do works? We want to know if Cheryl's program works, and if not, did they go to the next step? And at the next step, they're just not coming to the next step. So we can't give any numbers back to Cheryl if it's working or not. So.
I want to add too, unfortunately, the state of Ohio, like most states, is we're very reactive, we're not proactive. And that's a huge issue, like, let's say gambling, for example. I will say, if I asked an administrator at a school district, is your students having problems with gambling, they would be, not our students. Just like not vaping and drinking and stuff too, but, they are. And it's actually it's again gonna be something that's gonna become very common, and already has, because we legalized, well, I didn't, but, sports betting has been legalized. They do it at home on the couch, just like they do a lot of things at home on the couch. And we're already starting to see an increase of students doing that, and that, I truly expect that's gonna be the next huge epidemic issue that we're having, is youth gambling.
So it sounds like it would be beneficial for some cross communication group. Is there someone in mind that you could think that would be a facilitator for that? Are there already bits and pieces of that in place?
We have had gambling prevention, evidence-based curriculum for 15 years, and we've never been able to do it in anywhere, because there's no problem.
We have, I think we have the only treatment provider for gambling as well, Adam. Who got certified last year to be a gambling specialist. The state always wants more money, so they, take extra classes to get it specialty, but they do learn a lot of evidence-based practices for gambling. Adam's ready to go, but, we'll get a call from Cleveland and says, well, go to Cleveland, you're not gonna come all the way to LAPP for treatment. But that 1-800 number that you see after all the online betting, that comes to us if a call's coming from Licking County, to get routed to Adam. And we've had like 4 calls within the last, 6 months. Those are adults, because kids aren't legally able to gamble. So I think that's gonna be a huge barrier trying to get treatment to kids too, because they might be suffering, but they can't dime themselves out that they've been gambling. So that's gonna be hard to cross over and try to figure out how did they get that account? Did they fraudulently do it? And then you might have to deal with her. So I mean, it's gonna be interesting how it plans out with gambling. I look at it from a legal aspect too. I worked in juvenile court before I took this job.
We're seeing
So-
parents actually creating accounts and letting their youth use them.
And do you see, and I'm not sure if you even have data for this, but is there crossover between kids who are gambling and kids with substance use disorder?
Yeah.
Absolutely. That's even in adults, there's multiple addictions. A lot of times it's not just one substance, it's multiple substances. Sometimes it's, shopping in the substance. Sometimes it's gambling in a substance, addiction across the board go hand in hand.
So that's a really good lead in, actually. Thanks for setting up the next question. So what are some early warning signs that we should look out for, that families, schools, other, youth peers can pay attention to, maybe some of these behaviors, or if there are other behaviors that are early warning signs that we should be aware of?
There's a lot of them, and they're broken up into different categories. When I did work at LAPP and work with school districts, there was like a early warning sign, and I'd make copies and take them to the school districts, and the schools would put them in their teachers' mailboxes or whatever. Because again, it's if they understand. We've done trainings at like a certain school where the teachers, I went in and talked about drug trends that we were seeing, and then drug task force came in after and brought in the drugs, the paraphernalia, to show teachers how the kids are hiding it, and it's easy. Unfortunately, it's easy. Highlighters, bracelets, or smoking devices. Companies are making it easier and easier for kids to do it. But you have to know what to look for. So I could go like really long on this too, but there's behavioral signs to look for. It could be sudden changes in behavior or the personality, declining school performance, loss of interest in things they were interested in before. Social signs could be, new friend groups, moving to groups where it's more accessible or acceptable. Isolation from family, avoiding family activities, going to frequent parties and they didn't before. Physical signs could be, depending on the drug use, red and glassy eyes. We all know when someone smokes marijuana, they're gonna have the munchies and they're gonna have red, watery eyes, not necessarily vape, but unexpected injuries that could occur, smell, obviously smell of alcohol, smell of marijuana, neglect of personal hygiene or their appearance, now they're getting detentions more often at school, obviously legal charges, possession charges, things like that. There's a lot of signs to look for if you're educated on what those are.
Yeah, I think Cheryl hit pretty much all of the ones I had on my list. Changes in behavior, changes in peer group, drop in grades, physical appearance, even mental health issues can be triggered as well. And I think you covered everything else, just for the sun.
I think it's the same with mental health or substance use. You're gonna see the same things. You're gonna know if something's off. If it's something off, there's something going on. You don't have to automatically assume it's substances, but there's something not right. Just ask them. Just ask what's going on and notice you changed lately, and the response is gonna probably show what it is. If they're more apt to hide it, they're trying to hide something, right? If they're open saying, I've been just not feeling myself the last couple days, probably not substance related, might be depression, might be anxiety. So it's response. You know the individual better than anybody else. You would know any changes. If it's, I don't think a teacher is going to not know their students that they see more hours a day than probably their parents do. Right, so they're gonna notice changes, not doing homework anymore, not caring, the attitudes start increasing. What we don't wanna see is they're a bad kid, let's send them to the doctor and get some ADHD medication. We don't wanna do that. Cause that's just gonna spiral a whole nother issue in itself, but, it just knowing the kid, who you're working with and how you can support them at that point. And as soon as there's a change, reach out and ask. If it's more than that, consult with somebody else. I'm more than willing to take a phone call and say, hey, I've seen this with this kid. I'm like, well, this could be going on. Would they be willing to do an assessment? That's as easy as it could be. Not saying that the assessment's like the end all, but it can tell a lot and gives them that space to be able to just talk freely about what's going on in their current life.
And it's really helpful when parents don't have the opinion of not my kid.
Yeah.
That's a huge issue. To be honest, educating everyone that addiction can happen to anybody, any age, any socioeconomic. I see a lot of that, not my kid, a lot of that, these statistics.
So how can families support a young person in recovery? Are there any effective parenting strategies, parenting resources, whether that's groups, programs, materials that could be really helpful that folks should know about?
When I talk to parents, I tell them there's some things that they could do, stay calm and open-minded. Sometimes we have parents that don't have connections necessarily with their kid. If they catch them using a substance, it's automatic punishment. And they don't understand. I grounded him, took his phone away. He's not allowed to smoke. He's not allowed to vape. That's not how addiction works. So it really is educating the family on what is addiction. you know, it's not just a choice they're making at an addiction level. But there are a lot of, when we go into school districts, we tell kids, you know, if you have questions or concerns, or you want to know about substances, and you're going to the internet, let us give you some credible websites. So we give them less of websites where they can get information from. We have some students that come up and will be like, my parents won't stop vaping, or my, you know, so we'll say, okay, so I'll bring information in, and I tell them, please understand it's legal for your adult parent to drink or whatever. Really, it's their choice, but if you want to give them this pamphlet on this information, that's great. I'll give this resource to you. We always tell them to call 211, obviously, and we do that a lot. We take 211 988 cards into the school districts. We give them to the teachers so they have them. But we also hand them out to the students if they want. Anytime we do vaping curriculum, obviously it's prevention. The kids maybe aren't saying that they're vaping, but we give them like a half sheet of paper. We created a adolescent vaping resources, like phone numbers and agencies they can contact to talk to people and things. So for us, it's just a huge thing of giving them resources.
Same from the court's perspective. We try to link them up with services, give them resources, give them information that we have available. We also encourage parents to participate in counseling or treatment with the youth, especially if that youth is asking them and really wanting them to be a part of that. We encourage family members not to be using in front of the children, not to have it available in the home. We do also go over with the youth about they're adults and they're allowed to do these things, but then kind of take the parents to the side and kind of give them some advice about that or suggestions on how not to be doing it in front of the youth. Yeah, I think that covers about everything.
So working with youth in a treatment setting, we really focus on, it's not important what other people do, including your parents, when it comes to your health and being healthy. So we're focused on their disorder and how they can overcome and live with this disorder and navigate life regardless of the temptations of family members or extra people in their life. So we have that discussion with them. However, what we do is try to educate the parents during the treatment. Hopefully they get something out of it too, because they need to, if that's the choice that they make to continue to use whatever substance it is, either, you know, vapes, nicotine, alcohol, whatever that is, to how to respect the child's wishes of remaining abstinent and living productively without a substance, you know, that education. And sometimes that involves into the parents making some decisions saying, hey, you know, I should be a better role model, right? We have a lot of adults that it's generational that come through our building. We've had grandparents, parents, and kids in our building at the same time. Huge change when all three of them are going through treatment. That's probably some of the most successful stories we see. Like, because they're working through it together. Even though they don't have a clue what they're talking about, they're working through it together. They understand it. They're like, oh, this is why I need to do it. I need to be more of a role model to him so he can be a better parent to his child. We see it all the time in our building. They're connected in 2-3 different systems in our building and just a growth from that. So we try to get any support person or family member in treatment. Unfortunately, with the adult population, that's very hard because their support people a lot of times are the same people that they used to get in trouble with. And then their parents have already like turned their back, but parents can't turn their back. They have to be there, but they have to also be there emotionally, physically, and mentally for that child.
All right, thanks so much for all that information. Again, if you have thought of any questions that you would like to ask our panel, please go ahead and write those on the slips of paper if you haven't already. We have one more question for them, and then we will be able to have some time to ask your questions. So if you would just hold those up, Ashley is going to come around and collect those for you. So panelists, so that we don't just get kind of bogged down in the work at hand and think about all of the kind of negative aspects of the conversation today. I thought it would be nice to end on a more uplifting note. So is there a success story, or maybe a bunch of success stories, but something that you would like to share about your work? That's more of a kind of a success, or, you know, something like that.
What I'll say with prevention is the longer we're in a school district, we do get to see that the students have the choices they've made. So that can be helpful because a lot of times, you know, in treatment, you don't know how they're doing unless they've reoffended or they came back for treatment. But I have a couple really good stories. One I wanted to end with, I looked this up. It says in the US, a large proportion of adolescents still report not using substance. So for an example, in 2023, the National Survey of Drug Use and Health data showed that among 12 to 17-year-olds, 73% reported no past use of illicit drugs, marijuana, tobacco products, alcohol, or nicotine vaping. So 73%, now that is much lower. It used to be in the 80s, then it was 85. So 73% is still good because it's a majority, you know. So that's really good information. That's not everyone is doing it. It's really important to me. But we have seen, when I had left lab and went to Pathways, someone had come, I was in a building one day and I came back and they were like, it caused chaos in the agency because we have 211, and so there's things that come along with that. And they're like, someone came looking for you. I don't know how they know you work here now. But he was asking about you. He wanted to see you. He said you used to work with him and he's gonna come back. Like everyone was panicked, like, because you know, you never know if someone's upset that I did treatment with before, or maybe they went back to jail because I reported it to probation, you know, something. It actually ended up being one of my adolescent clients who is now an adult, and he came because he wanted me to see how well he was doing. Brought me his business card, told me, then he ended up saying like, I need you to work with my girlfriend. And I'm like, okay, that's not the hat I'm wearing anymore. So I gave him a lot of resources and things. We don't get to see that a lot. Prevention, absolutely. We may see a fifth grader and never see that kid again. But what we have found is, I'll give a couple examples. We had one school district we were in, it was sixth grade. A student ended up at the end of, we did 8 days of drug prevention with them, so that last 2 months. And she ended up raising her hand and she wanted to thank us for coming because her and her friend had a plan to start selling drugs to make money. And because we came into her classroom, she was no longer gonna do that. So we sometimes do hear stories, or years later, we'll see a student that we saw in sixth grade and they'll say, hey, I made these changes and that kind of thing. It's not very often, but we do get some, so that there is good going on, and so.
And I think from my perspective, the positives we see are more on behavior modification or preventing more criminal involvement or charges. And we have had some youth, such as like what she was saying, that were like selling drugs, and after the court involvement and we started doing some different things with them, they opted to go a different route besides selling drugs. They started, you know, working, and one worked, bought his own car, things like that. So they were able to demonstrate some success that way, and that was a good thing. So I think that is kind of what we hope to see from the court perspective, not really regarding substance use, but maturity, maybe doing some behavior modification, interventions. We've been trying to do like a lot of strength-based work with the young people we're working with. So I've also worked with one of the other mental health agencies. We've done things like introduce kids to like pickleball, frisbee golf. You know, at first they're like, okay, what is pickleball? And they had no idea. Same with frisbee golf, trying to teach them other activities besides what they've normally done with their peer groups that were not so positive, such as selling drugs and using drugs and all that stuff. So that's been an interesting opportunity that we've had, and it's been a lot of fun really seeing the excitement and spending the time with the kids like that and seeing them actually as just being typical kids, getting to know their sense of humor a little bit better. And that's been something I really enjoyed.
I think, I'll just share our stats from last fiscal year that ended June 30th. We served 46 adolescents, for the year. And 91% completed successfully and met their treatment goals. Treatment goals means gotten off probation and remain abstinent from a substance their entire time in treatment. We try to get surveys afterwards. It's hard. It's hard to get them to do a survey when they're in person, but To get it 3 months out is hard. But what's changing is just wearing this shirt. I might not even see that kid. Come up to me and says, I went through there, it worked. So those are the little nuggets that keep us going to do what we do. So that's why I wear it everywhere, just to get recognized. No, but it is comforting because at one time they didn't want to have anything to do with LAPP. But now that they're in a better headspace, they're coming on and saying, I know where that's at, and it helped out. There's a lot of kids, like my daughter, she didn't come through as a client, but she'll go around, she goes, hey, they need a business card. I can't do that. But when she was in high school, it was ridiculous. She wanted her to send everybody to me, and I was like, no, you can't do that. But, you know, I think that speaks volumes of what we do, is when former clients say, hey, that actually worked. So that's all I got.
All right, thank you. Appreciate those stories. It's always, I think it's good to end on a note that's a little bit more uplifting. When we've had a heavy conversation. So I appreciate everybody's questions. We received 16 questions from the audience, so unfortunately, we're not gonna be able to get to all of those. But I'm gonna try to do my best to condense some of these that have similar points to them. So I want to start off with one, because throughout this conversation, we've mentioned that younger and younger kids are seen, especially with vaping or using other substances. And Cheryl, you mentioned, you know, going into an elementary school where they're like, well, we don't have a problem. That's the perfect time to talk to them. So someone asked, how do you talk to younger kids, especially maybe if they're even K2 age range? What substance, or how would you talk about them about substance use in ways that they would understand?
Well, each curriculum, we actually have curriculum for each grade, so it's age appropriate. What we have found, unfortunately, since COVID, and I don't really like to blame a lot of things on COVID, but what we have found is, you know, these developers that do this programming, the kids are not up to educational level of what the actual curriculum might be. So if we meet the students the first day, kind of get an idea, talk to the teacher. If we're doing a 6th grade class, but they're developmentally or educationally not at a 6th grade level, then we'll bump down to 5th grade. We really get to know our students, and then when we go from year to year, we see a lot of the same kids. So we get to know them as well. So it's age appropriate. We also, again, talk, because sometimes we'll go into a district and they'll say, hey, just want to let you know, 6th period is developmentally delayed. So their curriculum has to, obviously we have to adjust the curriculum. And the good thing about prevention is we get to have fun too. We have educational information we have to do, but we actually, I mean, they get excited when we come in. Usually it's because the teacher isn't going to be teaching them something they say. And I'm like, well, you're still learning. You're just learning different types of information. One thing I will say is students do not like to learn about social emotional learning as much as drugs. So even though I'm like, guys, social emotional learning is extremely important. How to be a good friend, conflict resolution, you know, decision making, all those things are extremely important. But anytime we see a student the next year, we're like, we saw you last year. What did we teach you? Marijuana's bad. I'm glad you remembered that. So, which we don't say that way, but, so.
Yeah, but do you think social emotional, I mean, that is the huge first start to all this, don't you think?
Absolutely.
Yeah, we
And
can talk about.
we have-
Order if they're not kind of prepped in that.
Right, if they don't know how to make a decision, and we already know adolescents have difficulty with that because of the frontal cortex, frontal lobe, but, yeah, that is all part of it.
Yeah, like.
But
we
a lot of
teach that
schools-
before sexual health,
Right,
like.
absolutely.
Yeah.
Like bullying, I've literally had, you know, a high school reach out and say, hey, can you come in and do bullying with our high schoolers? I was like, no. If you have a problem with bullying in their high schoolers, us coming in for 4 days to try to talk to them about bullying is gonna change nothing. Even younger buildings with bullying now, we're like, you know what? It's great for the students that get it. All your students need it. And it needs to be a culture change within the school district. So
Yeah.
we really are being much more, I don't wanna say, we're giving a lot of feedback. I mean, if a high school says, hey, I have a bunch of kids that got in trouble for this, come do education. I'm like, I'm sorry, you need to contact LAPP. It's a treatment issue. We're trying to make sure we're doing the best services, where it's absolutely needed that we're gonna make the best progress with the kids.
Can you quickly expand? I know you touched on it a little bit just there, but one of the questions actually someone had asked, was what is social emotional learning? And so it's obviously a critical aspect of this, and you did kind of speak on it a little bit, but if you could just give a quick rundown. of what
Okay, so
that
social
is.
emotional learning, actually, ODE requires that all school districts in Ohio teach social emotional learning. So it's different topics, like unit 1 is goal setting. Unit 2 is decision making. There's conflict resolution, there's, effective communication, which is an interesting one. They're like, well, I can talk. I'm like, well, that is not necessarily effective. So, we teach them what is effective communication. And a lot of times communicating is just not talking, it's listening, and how important that is. And so, there's a whole lot of topics that we talk about, how to be a good friend, but not only that, how are you treating yourself? What are things that you need to do for yourself, mental health wise? We talk about mental health disorders, and we don't go into detail, and I don't diagnose and all that kind of stuff, but we do say, like, here's some resources, here's some ways to, if you feel sad one day, here's some ways that you can handle that, feeling sad that day. Now, obviously, if it's ongoing, it could be depression, and we recommend that you reach out to a mental health facility. But so it's an overview of skills that everyone needs to have in life to be more successful.
Thank you. So we received 3 or 4 questions, all kind of around, schools. And from your perspective, from anyone's perspective, really, are there anything that other community leaders, organizations can do, to help get some of those connections with schools, with prevention, and I guess treatment providers as well?
Well, I think John mentioned it the first. I am huge about collaboration and communication and meeting people. I think the first year I was at LAPP, I spent the first year just going out in the community, meeting school administrators, going to court and talking about what we were gonna do, getting to know the probation officers. That collaboration and relationships are very, very important. So I spend a good portion of my time still doing that because it's important. And it's also like, so say, for example, we had one school district that wanted a lot of services, which is great, but they're a very large school district. And we did go in and do prevention services for their entire 4th grade. They had 493 4th graders that we did 8 days of service with every student. So sometimes word of mouth doesn't always, like, they're like, oh, that was a great program. So they talk to another school district and we're like, wait a minute, we only have 4 employees. So that's a problem in and of itself too. There's so many buildings we could be in, but unfortunately, we're first come, first serve, so it's kind of like if we're scheduled full, that's all we can do. But, I go to guidance counselor meetings for the month from all the school districts that meet. I'm scheduled to go to superintendent meetings. It's just about like knowing who the key people are, and also the turnover has happened a lot. So it's like almost starting over sometimes. When teachers retire and we've been in their school, the new teacher may be like, I don't see a benefit in this. So then it's like you have to re-educate them and get back in that building. So it's just about communicating and building rapport with the districts and the community.
Hey, Court, can we find out how many school districts are here today?
Here, I don't think anybody from the school district is here today. Oh, hello, I don't think I know you, so I'm sorry. So we've got Granville, thank you. Anybody else? I don't see anybody.
Well, I would say in 2023, we were in 8 districts either at one grade level or another. In 24, we were in 7 districts, and I'm not sure how many districts. We're probably about 7 right now, 7, 8. So, but it may just be we only see the 5th grade class in this building or something like that. So
Yeah. Now, I will say, as far as these programs, we do get involvement from other school districts, folks that are here. We are also this morning, there's a conflict with another mental health and recovery event happening at the same time this morning that a lot of folks are at that are usually here. So today, unfortunately, there's not a whole lot of representation, but I know even in our work outside of prevention, working with the schools for education for all kinds of things is really critical, and that's something that we've been really working on as well. And there are districts that We had our last forum, last month was on public education. We had a really great representation on our panel. So, you know, what we find is that school districts are usually quite willing to work with us, work with, you know, whether it's United Way, other social service agencies. That's not the issue. What we see a lot of the time is staffing, being able to provide enough resources to cover everybody, because we are a huge county and there are a lot of school students in this county, and a lot of schools. I mean, I don't even know how many elementary schools there are, and probably
Newark has 5.
in the thirties
Heights
in the whole
has
county
3.
at least, so,
So
There's what, 11 school districts in the county?
yeah.
Right.
11 or 12.
So I say as a parent though, talk to your administrators, you know, talk to the school guidance counselors or, you know, go to a meeting, like, because sometimes it's difficult for us to even get the time, like, say, for example, I reached out to go to the superintendent meeting and they were like, you know what? We don't have the time, so just send us an email of what you guys do. We know getting in front of those administrators are going to be the most effective. Because we all know we're inundated with emails and a lot of times they don't get read or they don't understand. But for us, it's people understanding what prevention is. And then, once we get a district on board, they're on board and the teachers and the administrators are reaching out. Even for the next school year, like I know it's first come, first served, please get us on the calendar. So we have good rapport.
Yeah, and like I said, you know, school districts, generally, we found they're extremely supportive. I mean, the community organizations are there to help them with their mission as well. And so usually, once you get your foot in the door, that's always really beneficial to get into other districts too, because they're like, hey, this is great. You know, they can kind of help as well. So, you know, I don't wanna, the fact that there's only, you know, Granville represented here, that's not a representation of the support of the schools. But it kind of speaks to an issue that we all deal with in terms of trying to do everything and be everywhere all at once.
Counting brick and mortar religious schools, there's 22 elementaries in the county.
Wow, so a lot to cover.
That's one we have not been able to crack into. So,
That's the guys.
a lot of them, I didn't know that.
So, you know, with LAPP focusing on the mild and severe cases, you know, we're talking in high schools. You know, high school is gonna be where majority of our folks are gonna, you know, be and that would need services. All the high schools have reached out. We have communication when it's a crisis. When that crisis doesn't get resolved right then and there the way they want it, it kind of gets put on the back burner because they're like, we'll just suspend. Or, you know, there's other methods and not trying to do harm. It's just what they have set up, right? I think, you know, we need to have these discussions when it's not a phone call like, hey, I need help now. It's, hey, let's plan for next year. One school district, like Cheryl shared, you know, we planned for a good year before we ironed out kind of like the steps. And we just ironed it out right before school started this year. Haven't really seen too many referrals come in, but it's first quarter, so we'll see. But yeah, I think that's when the communication needs to happen, is not when it's dire, but plan. Do the preventative thinking about treatment. That's the biggest piece.
I just want to add real quick, from a school perspective, we see so much when we're in the buildings. So I want to be very fair to the school districts. The schools are dealing with so many issues. They're dealing with a huge increase of mental health diagnoses in their students that have impact. They're dealing with food insecurities. They're dealing with financial issues from the families. They're dealing with families with drug addiction, state testing requirements and things like that. So I'm very gracious and appreciate all the school districts that we get into, and we really enjoy the time we spend helping the teachers in the classrooms that we go into. But I want to be fair. Schools are overloaded with so many different issues that they're trying to take care of.
All right, another question, similar, and we kind of mentioned, Jeff mentioned also the religious, elementary schools, and said that was something you have not been able to crack into, but, does the faith community partner with you in any way? Are there resources that you can use there, to help address these issues?
I think I'm not sure about Heather, but I know I'm on like a 8 different coalitions within the community. So we do have relationships and we do talk to them about. We've gone and done things in the summer for a youth group, because obviously schools are closed in the summer. So I know next summer, literally just about every day of the week, we actually contracted with the YMCA. So we will be doing the summer camps. We're doing Muskingum, Johnstown, Tascala, and Newark. So 5 days a week, my staff and I will be in doing, social emotional learning for the students that participate in the YMCA. So there's a lot of relationships that can be built, with community partners, religious partners, and I do know a lot because the coalition, so that builds up your rapport and relationships with other people in the community.
All right, so John, we had a couple of questions that were here, directed toward you. Someone was asking, currently, do you have groups or kind of like a group program for youth? And is there a wait list for individual therapy for youth?
We do not have any wait list for assessment or treatment services. We have groups built out. They're just not running because we don't have anybody to put in them. The individuals that we see, don't meet the criteria for that group, or they're not motivated to do the group. There are some conflicts, like if they're co-defenders in a case, they can't be in the same group. If they're family members, they can't be in the same group because confidentiality, a lot of things like that. So there are various factors that prevents them from going in a group. One group that we used to have, and we do currently have, is I call it early intervention, but the state kind of makes it ugly for us sometimes, but we do an education group if they had that mild diagnosis. We do have that group running. It's usually every other month that we hold it. It's on a Saturday, so they're not missing school, and it's like 6 to 8 hours of education packed in. But it's a good time. I mean, it's good information. And we kind of go over like treatment on steroids. Cheryl built that program. When I was working part-time, I'd cover when she was off, and then when she left, I inherited it. And then I passed it on when I had too much other responsibilities. But it's the same curriculum and it's good content. So we do have all that available now.
Okay, and then how would you engage with a youth to try to complete a diagnostic assessment if they're refusing to engage in treatment? Is that just anything you can do beyond that point?
I mean, they're gonna have to consent to begin even starting. There's a misconception that if they're a minor, they can't have any treatment or services. That's a false. In the state of Ohio, they can be seen by a treatment provider up to 6 times without parental consent. So that breaks, alleviates one of the barriers. Cause there's some kids that actually call and say, hey, I don't have a ride up there, but I really need help. But my parents aren't gonna agree with it. We've had those calls too. Unfortunately, we can't go get a kid and pick them up and bring them in. So we try to do the best we can, but a lot of times they'll have somebody's friend or something bring them up and they sign their own consent. At that point, they'll engage. But if there's a very resistant client, we're pretty good at working with resistant clients because all of our adults, I wouldn't say all, majority of our adults are resistant because they don't want to be there in the first place. It's just building that rapport, just making them understand that it's a safe place. Nothing's getting shared that's not detrimental to their safety or ethical concerns, but it usually doesn't happen. I mean, kids are pretty open. They could be lying, some of them might be lying, but that's something that we take as an opportunity for growth. Just because they lie in an assessment, that's just where they're at right now. We got something to work on. So we really don't have too many resistant kids that just flat out refuse to do it.
Okay, I would say we have time for one more question here. So, this question, it says in the court system specifically, but I'm sure this would apply to all of you. If there's a youth who is, engaged for some reason for substance use, whether that's with the courts or with treatment or something like that, are there any kind of prevention or support services that are given to their siblings or their younger siblings or other family members? Is that a potential thing that's even possible?
That would be something that we could refer for services for the family. It's not necessarily a given that that's gonna happen, but if the parents are asking for information and ideas, then we would gladly refer them to community resources.
And for us, we may never meet the sibling, or, again, if a student says they need information on whatever, we bring information in. Again, we always take in the 211 cards. We were doing, victim presentations in a 5th grade class, and a student said, well, my sister vapes. So we're like, okay, how old's your sister? And he's like, oh, she's across the hall. It was his twin who was in 5th grade. So obviously, we're going into that classroom, so they're gonna get some information as well. So our circumstances are a little different.
Yeah, for ours, like I said, we try to include the whole family. We get all the family dynamics and the relationships in the assessment. Find out what their barriers are too, because that could affect the person that we're working with. We would make recommendations to a parent or child or whoever can make that decision. Usually it's the parents who can act on a recommendation that we give. There are several providers that nationally known to work with families. We are not known to work with the family unit. Ohio Guidestone, you got NIA, Buckeye Ranch, you got all these other organizations that work with family specific. That would just be a referral to additional services, to address the family stuff. So, I mean, there's services out there. If it's out of our scope, we refer.
Well, it depends on the agency too, because like example, Mary Haven, if a person is a client and involved in services, they have Ask a Doc. Like, I think it's one Saturday a month or something, and the family can come in and get services as well. I think more treatment facilities are trying to do more family services. It's a billing issue, to be honest. A lot of insurance companies will pay for the person themselves that's in need, but not necessarily the family, which we know the family dynamic is all impacted. So we're seeing some changes in that.
All right, well, let's give our panelists a big round of applause. Thank you so much. That was really, really informative, and I think just a really important conversation. So I appreciate that. Thanks to all of you for coming and joining us this morning. If you haven't already, make sure you grab the 2026 Community Partner Council Forum schedule with all of the topics of 2026. Next month, in December, we always do kind of a social thing, but we will be doing a service project along with that. So join us. Next month is December 10th, and we will be doing a drive for our Hygiene Hub. So if you're not familiar, Hygiene Hub is a program that places supply closets of hygiene supplies. We are in all 11 public high schools in Licking County, as well as some other locations, and we're expanding. So we're gonna be doing a hygiene drive, specifically asking for deodorant, shampoo, body wash, and laundry detergent. Those are kind of the more expensive things that sometimes we have a harder time keeping in stock. So those are the objects that we're gonna be looking for specifically. Please join us. December, usually we don't have a panel discussion. We do a service project, we have social time. We've kind of started our tradition of making holiday cards. So all of that is gonna be a good time. And then back in January, we are back to our panel discussions. We will be talking about caring for kids, a conversation on fostering and kinship care. So that will be another very important conversation. As Deb mentioned this morning, we're gonna be sending out information about our nonprofit expo coming up in February. So we will be getting folks on the list to exhibit for that. Gonna be a little bit different. We're shifting the time more toward late afternoon, early evening, to try to capture some better schedules for folks. So information is coming out on that. Make sure you grab one of these. Join us next Tuesday for our conversation at the Doubletree about financial stability and risk for housing instability in Licking County. Patty, did you have something?
Well, I do.
To pre-order.
Always, right? This is such a knowledgeable panel. I appreciate you. But let me tell you how far we've come. When I first started in mental health in 1981 and went to every high school to talk about mental health and issues, one of the principals said, well, we don't have any high school, any kids having sex, drinking or something. So that's all gone, I hope.
That's normal development. We know it's happening.
With Dr. at Shepherd Hill, who insisted drinking alcoholism was a choice. it had nothing to do with a biological brain disorder. So that's way beyond, hopefully. Thank you.
Was a choice.
Well, thanks, Patty. And again, thanks to all of you for coming. Feel free to grab some food left over there if you would like, and we will see you next month, December 10th at 10 a.m.
Where's the next event?
Sarah,
Yeah,
Sarah,
Sarah,
yeah.
Sarah.